My name is Dr. Alnoor Abdulla. I'm a cardiologist from Vancouver, Canada. I would like to thank the organizers of this conference for giving me the opportunity to make this presentation to you today. I am basically going to give you an overview of some of the recent advances in lipid management. I have no conflicts to disclose with regards to this presentation. With statin therapy, we know that with each millimole reduction of LDL, there is approximately a 20% reduction in adverse cardiovascular events such as stroke, myocardial infarction, coronary mortality. And with statin use, all-cause mortality is also significantly decreased. And this benefit occurs without there being an increase in non-vascular mortality or in cancers. So statins are highly effective. The problem is that of statin limitations, which includes intolerance to statins, variability of statin response from patient to patient, the suboptimal adherence of statin therapy over the medium and long term, and the insufficient lowering of LDL cholesterol. When you look at statin-associated adverse effects, there are those that are caused by statins and occur in about 6 to 10% of patients. And then there are symptoms in patients who are taking statins, which are attributed to statins. And these are primarily related to the nocebo effect, a situation in which a patient develops side effects or symptoms that can occur with a drug just because the patient believes they may occur. It's a result of negative thinking and fear. And this is generated primarily by the late press, social media, anecdotal cases, etc. The variability of statin response is also a problem. The same dose of statin can cause a very different response in LDL lowering. And this occurs in men and women as well. So there is variability of patient-to-patient response. The other pharmacodynamic problem with statins is that they have a flat dose response curve. So with the initial dose, you get a significant reduction in LDL, but when you double the dose, you get only another 6%, and you double the dose, you get another 3%. So you have what we call a flat dose response curve, significant initial benefit, but then with doubling of the doses, there is very limited further benefit. Statin adherence is a big issue. Drugs don't work in patients who don't take them. So that's a big problem. This is data from 15 trials in patients who all had myocardial infarction. So these were patients who already had coronary disease and had a heart attack and were put on statin therapy. And you can see that recurrent myocardial infarction was prevented and all-cause mortality was decreased only in those who adhered to their statin therapy more than 80% of the time. The issue of insufficient LDL lowering is a problem, particularly now in high-risk patients, where only about 65% of high-risk patients actually reach LDL targets with all the lipid-lowering therapy we have. So the use of ezetimibe helps with lowering the cholesterol further, especially when used in combination with statins. Ezetimibe decreases the absorption, and statins decrease the production of cholesterol. And with the dual inhibition, you get a further significant lowering of cholesterol in the blood. In this case, you can see that with full dose potent statin therapy, there is reduction in LDL cholesterol, but when ezetimibe is added, there is further reduction in cholesterol levels. And more patients are able to reach the target levels or their goals with the use of combination therapy. The advances in lipid-lowering therapy that have occurred recently deal with the PCSK9 protein. PCSK9 is a protein enzyme that's produced in the liver. There is the PCSK9 gene, which translates to the messenger RNA for PCSK9, and the messenger RNA leads to the production of PCSK9 at the Golgi apparatus, and the PCSK9 then enters the circulation. So now you have PCSK9 in the circulation, you have LDL and other atherogenic lipids in the circulation. Our aim is to clear the LDL from the circulation by getting it into the liver cell and excrete it in the bile. So the clearance of LDL from the circulation into the liver cell is a very important issue. So how does PCSK9 impact that? So in the presence of PCSK9, which is produced by the liver, the LDL particle attaches to the LDL receptor, but the PCSK9 also attaches to the LDL receptor. So you have what is called a triple complex. This triple complex undergoes endocytosis, and because the PCSK9 is attached to the LDL receptor, it cannot be cleaved off and recycled back to the surface of the liver cell. All of it goes into the lysozyme and gets degraded, and the LDL receptor is lost. So there is a decrease in the density of LDL receptors, and there is downregulation of LDL receptor function and less clearance of LDL from the blood. So PCSK9 is bad. If you were able to inhibit the PCSK9 by attaching it to a specific directed monoclonal antibody so that the PCSK9 cannot attach to the LDL receptor, now you have the double complex of the LDL particle and the LDL receptor undergoing endocytosis. And in the endozyme, the LDL receptor is cleaved and recycled back to the liver surface to clear more LDL, and the LDL particle in the liver enters the lysozyme, is destroyed, and excreted in the bile. So inhibiting the PCSK9 is a very important mechanism by which to lower LDL cholesterol. So we inhibit the PCSK9, increase the LDL receptor density and LDL receptor function, and lower the LDL levels in the blood. There are two monoclonal antibody PCSK9 inhibitors available, evolocumab and alirocumab, and these are available, and the patient can easily self-inject them into the subcutaneous tissue. When injection is given every 2 weeks or a higher dose given once a month, there is significant lowering of the LDL cholesterol, which remains sustained and lowered for a long duration. So the medication is only needed to be given once every 2 weeks or once every 4 weeks. In the Fourier trial, there were a large number of high-risk patients with atherosclerotic coronary disease, but did not have their LDL cholesterols within target range despite statin and other lipid-lowering therapy. These patients were given evolocumab, which significantly decreased the cardiovascular event rate over and above those patients who were taking statins and other lipid-lowering therapy. This benefit was seen within the first 6 months, and the benefit continued to increase over time. So the PCSK9 inhibitors are highly effective and fairly safe without increasing any neurocognitive adverse events. without increasing rhabdomyolysis, without worsening liver enzyme elevations, without producing new onset diabetes or any risk of allergic reaction. The other way that we can lower LDL cholesterol is preventing the production of PCSK9. So if we were to interfere with the messenger RNA with a drug that enters the liver cell and blocks or inhibits the function of the messenger RNA, then no PCSK9 is produced, and this leads to a beneficial effect of clearing the LDL cholesterol. One of these newer drugs is inclisiran. It has two parts: the small interfering RNA strand and the conjugated end, the conjugated terminal end of inclisiran. The conjugated terminal end allows the drug to be specifically taken up in the liver cells only because it attaches to the ASCBR receptor, which is only present in the liver cell. The receptor is then recycled back to the surface to continue to rapidly clear any of the inclisiran from the plasma into the liver cell. So we now get the drug into the liver cell, which is where we want it to act. And in the liver cell, this small interfering RNA attaches to what is called the risk particle or a risk complex. And this recognizes the messenger RNA for producing PCSK9, attaches to the messenger RNA for PCSK9, and prevents it from producing PCSK9. It degrades the PCSK9 messenger RNA. The other benefit is that attached to this risk complex, this stays in the liver cell for a very long duration. So it continues to block the action of messenger RNA in producing PCSK9 for a long duration. And so it is a long-acting drug. So you decrease the production of PCSK9, improve LDL receptor function, and lower LDL cholesterol significantly. So if an injection of inclisiran is given, there is rapid and significant decrease in LDL cholesterol. A second injection is given at 3 months to prime the system. And from there on, you only need to give the injection every 6 months to maintain a significant, consistent, sustained decrease in LDL cholesterol. So the drug is highly effective. What we are awaiting is the results of the Orion Fall trial, which will give us information about the long-term effectiveness, and it will give us information about the improved cardiovascular outcomes. The third advance in lipid management deals with the issue of residual cardiovascular risk. Residual cardiovascular risk are cardiovascular events occurring despite the patient being on lipid-lowering therapy. So you have patients who are taking statins, either standard dose statins or high dose statins. They have a significant decrease in major cardiovascular events compared to placebo, but they still continue to get major adverse cardiovascular events. The events are not dropped to zero, so there is still continuing residual risk. One of the reasons for this continued ongoing residual cardiovascular risk is that there are other atherogenic lipoproteins aside from LDL, which can continue to cause cardiovascular events. And these other atherogenic lipoproteins are triglyceride-rich proteins. So triglyceride is important in continuing to cause further cardiovascular events. So if you look at statin therapy, yes, it decreases cardiovascular events compared to placebo, but this decrease is mitigated based on underlying triglyceride levels. So the higher triglyceride level patients tend to get less benefit from decreasing cardiovascular events with statin therapy. So one of the ways to lower triglycerides is with the use of fish oils. The omega-6 fish oils are known to be not beneficial. The omega-3 fish oils, EPA and DHA, are felt to be beneficial. But if you look at all the trials using omega-3 to decrease cardiovascular outcomes, you find that they used various combinations and concentrations of EPA and DHA. And the overall result was neutral. We were not able to show significant benefit. However, when you look at EPA and DHA, although both are omega-3 fatty acids, they have differing cellular vascular biology in terms of their action at the cellular level, at the vascular level. The EPA tends to improve endothelial function, decrease inflammation, and decrease plaque growth, at the same time as providing plaque stability and preventing acute cardiovascular events. So EPA is what you want into the system, into the circulation to improve cardiovascular events. One of the ways to get large amount of pure EPA into the patient's circulation is to use IPE, which is icosapent ethyl. Icosapent ethyl is a fish oil which can be manufactured in a highly purified state and is very stable with a long shelf life. So when you give oral icosapent ethyl in the bowel, it is digested, the fish oil is digested with the lipase, and EPA is produced. So the body produces its own pure EPA, which is then absorbed into the circulation, and you can get high doses of EPA into the patient's circulation with the use of IPE. In the REDUCE-IT trial, IPE or icosapent ethyl was used in patients who had hypertriglyceridemia to see if cardiovascular risk was going to be reduced. And in the REDUCE-IT trial, there were a large number of patients who already had atherosclerotic cardiovascular disease or had diabetes and 2 other risk factors, but the LDL cholesterols were well controlled. These patients had to have a mild to moderate elevation of triglyceride. And when icosapent ethyl was given, there was a significant, highly significant reduction in cardiovascular event rate with the use of icosapent ethyl compared to placebo, despite those patients having well-controlled LDL cholesterol levels. So what I have discussed with you today is the need to significantly decrease atherogenic cholesterol levels with the use of statins or with the use of combination of statins and ezetimibe. And if the LDL levels are not reaching target, we can add PCSK9 inhibitors. And in patients who are completely intolerant to statins, we can use PCSK9 inhibitors by themselves or in combination with ezetimibe. We now have this excellent new drug, inclisiran, which prevents the production of PCSK9, leading to significant sustained reduction in LDL cholesterol level over a long period of time, requiring really 2 simple subcutaneous injections in a year. So you get a jab of the injection and you are done for 6 months with your cholesterol being well controlled. The other advance is in the lowering of triglyceride in patients who already have LDL cholesterol that is under control, but the triglyceride is providing residual additional cardiovascular risk, and this can be done with the use of icosapent ethyl. The trade name is Vasipa, and this produces EPA within the patient's body, and the EPA levels rise in the blood and provide cardiovascular protection. In the near future, there are newer drugs that are going to be coming for the management of hyperlipidemia, and we are going to enter the nucleus and do more gene editing and silencing. So hopefully I will be back at some other conference and talk to you about these newer drugs. Thank you very much for giving me this opportunity to speak to you.